Good morning, everyone. Thank you for joining me here this morning, bright and early. And thank you to the meeting organizers for rolling with the punches here and making this a successful meeting despite all of the challenges that we have going on right now. Like Susan said, I'm Laura Dell'Aiera, and I am the clinical coordinator at MUSC. I took this position in July of last year. But prior to that, I was a perfusionist at the University of Rochester in Rochester, New York. And I have to give credit to the team there in Rochester for a lot of this content and a lot of this knowledge. I was very familiar with VADs because of all of the heart failure care that they do there. So despite my new position, I am talking on content that I really learned there at the University of Rochester. So once again, minimally invasive VAD insertions. The publications that have been done up to this point really focus on the surgical considerations for surgeons and physicians. So I hope to shed a little bit of light on what is pertinent to us as perfusionists. If you're not already familiar with our options for the VAD insertions for the adult community, on the left here is the Medtronic HVAD, and this was the hardware VAD up until 2016 when Medtronic purchased this for $1.1 billion. They purchased the hardware organization. And then to the right of your screen, you'll see the HeartMate II. That's an axial flow pump, now owned by Abbott. It was priorly a St. Jude VAD, and that was bought. St. Jude was bought by Abbott for $25 billion. So just a little bit of fun facts there. And then at the bottom, we have the HeartMate III VAD. Now, the HVAD and the HeartMate III are both centrifugal flow VADs. The HVAD has a slightly lower profile than the HeartMate III does. So that becomes very important when we start talking about minimally invasive insertions. And although they are very, very similar in size, the HVAD has a little bit of a leg up as far as the lower profile. So if you were there for the beginnings of the HeartMate II insertions, you probably know that it was first approved in 2008. And when this journey began, we were doing full median sternotomies, and really just going for the best possible access to make sure that we had great visualization, that the pump pocket that we were forming for the VAD to sit in was just right, the inflow sat just right, and especially that the outflow sat without any kinks, without any obstructions. So this is what we were doing back in 2008 when the HeartMate II was first introduced. But then we got pretty good at that. We were getting curious about what other options we had. So some surgeons then tried for a minimally invasive approach with the HeartMate II. We still needed that pump pocket. So you can see in the left picture here that we were going for a subcostal incision on the left side. And that HeartMate II was being inserted through the subcostal incision. They were dividing the abdominal muscles and then going through the pericardium and exposing the left ventricle from there. You can see in the right picture, this is sort of an iteration of this procedure where the outflow graft kind of traverses the thorax and goes up to the right subclavian artery. And that is just one of the possible outflow sites for this type of procedure. This wasn't an ideal procedure. It was pretty labor intensive, and it didn't make for a perfect ideal situation, because we would really like to connect that outflow to the aorta for the best possible flow, as well as concerns with hyperperfusion of the arm. So then we had this HVAD that came out. It was approved by the FDA in 2017. And as I said, it has that smaller profile. It has the centrifugal flow. And as you can see, the inflow connects directly to the LV. So this now means that we don't have to create the pump pocket. The minimally invasive options have really expanded since the centrifugal flow VADs came out. So Once this was approved, in Europe, it was approved a good bit earlier, so minimally invasive techniques started to come out where we were creating a left lateral incision, a thoracotomy incision, and then a mini sternotomy incision. And this was fairly successful in Europe. It came to the US and Canada in the lateral study. And in that study, we enrolled 145 patients across 26 centers. And the idea here was to make sure that it really was a successful approach. But what we found was that we were actually having better outcomes with this type of approach. So it continued on, and it was approved for this type of surgical approach. Just a few details about that approach in particular. The left incision is made at the 5th intercostal space. You're able to visualize the LV through that incision. Echo guidance is very, very important in this and many minimally invasive procedures, as you might be familiar. And then that upper hemisternotomy, the length of it is determined by what other concomitant surgeries might be going on at the time. If you're trying to repair or replace the aortic valve, you're going to go down to the 3rd intercostal space. If you need to do any sort of tricuspid procedures, you need to go down to the 4th intercostal space. But primarily what's important here is that you can visualize the aorta. And then finally, the HeartMate III was approved by the FDA. We had the Bridge to Transplant approval in August of 2017. And then we had the destination approval in October of 2018. But all of these approvals were for the full sternotomy. So, of course, in Europe, this had been approved for years, and they were able to start with some minimally invasive techniques with the HeartMate III itself. They did try that left thoracotomy, upper hemisternotomy approach, and had some great success with that. So my team at the University of Rochester, we started with the HeartMate III trials. We loved the VAD. We were implanting it via the full sternotomy and started to look at some of the publications coming out of Europe, in particular the University of Vienna. And they were able to start with a fully sternal sparing approach where they were doing 2 thoracotomies, bilateral thoracotomies. And we thought, why not bring this to the US? So at the University of Rochester, Dr. Igor Gosev decided that he was going to spearhead this effort. And we started to get some IRB approvals in February of 2018. And we, sort of a feather in our cap, we were the first in the US to do this for the HeartMate III. So you can see on the left here, we have the intra-op picture of how we were able to expose both the LV and the aorta. And then on the right is a post-op patient with the bilateral thoracotomy incisions. And really a very major surgery that we were able to do with 2 pretty small incisions. So I can't say enough about all of the people here, and really there are quite a few people who aren't pictured here that I would love to give some kudos to, but the picture on the left side of that picture is Dr. Igor Gosev. As I said, he's the one who spearheaded these efforts at the University of Rochester. If you move counterclockwise to him is Dr. Sunil Prasad. He's the chief of cardiac surgery there and really a very supportive chief. When people come to him with their ideas and their goals, he really supports that and makes it happen for them. And then again, counterclockwise to him, and really the reason I'm sharing this picture with you, that's Dr. Peter Knight. And what was really impressive to me about this effort was that this brought together a lot of people who wouldn't have normally been seen in the same operating room together. So Dr. Peter Knight is not a heart failure surgeon. He does not deal with mechanical devices, but he is the minimally invasive expert at the University of Rochester. So he was able to bring in all of his expertise with the minimally invasive valves and aortas and come into this VAD insertion and help Dr. Igor Gosev, the heart failure and mechanical device expert at the university, and their expertise really blended very well for a great outcome. And then to the right, if you have ever tried to get a picture of your entire perfusion team together, I think that you can probably commiserate with me here. This is about half of our team from the University of Rochester. And they are all wonderful people. There's several people who aren't pictured here that are equally as wonderful. But if you ever have the opportunity to pick their brains, they are a wealth of knowledge there. They've got a lot going on, a lot of very forward-thinking people. So I had to give a little bit of kudos to them as well. So for this bilateral thoracotomy procedure, the left thoracotomy is really very similar to what I've already shared with you. We would make an 8-centimeter incision also at the 5th intercostal space. What we had to do for this was shingle the 6th rib, and that was just to accommodate that slightly higher profile of the HeartMate III. And then you were able to expose the LV by opening the pericardium through that left thoracotomy. The right thoracotomy, this was slightly anterior. It was at the the 2nd intercostal space. It was a 4 to 5 centimeter incision. The 3rd rib was disarticulated so that we could expose the aorta through this incision. And then the pericardium, this is the very, very important part that our surgeons emphasized. The pericardium should stay intact as much as possible. They would only expose the aorta and really wanted to leave the pericardium intact over the RV. So that was access considerations. This is on bypass considerations. They had a very specific sequence of events that they wanted to cover as they went through this procedure. And in particular, through that left thoracotomy, they wanted to place the coring knife, core the LV, and place the sewing ring. But sort of the natural sequence of events at that point might be to place the inflow of the VAD. They chose not to do that. And the reason was because they needed to feed the outflow graft across the thorax up to the right thoracotomy. And that became really difficult if the VAD was already fixed to the LV. It wasn't very mobile at that point. So they would attach the outflow graft to the VAD, feed it through the chest, and make sure that they had access to it on the right side. And then they would put the inflow into the LV. So again, we had a series of 10 patients between February and April. We learned a few of these things along the way, but in their final publication about this procedure, that was their suggestion, was to feed the outflow graft through first and then affix the inflow to the LV. We always used CO2 at the field, probably a pretty standard practice for this. And then finally, the driveline placement, that actually varied depending on the patient, the body habitus, the anatomy, and then finally patient preference from pre-op conversations. So probably what most of us are interested in, the things that aren't published in the papers that they've put out, the things that are pertinent to us, the considerations for perfusionists. So cannulation, we started with a preference of doing femoral venous cannulation with a central arterial cannula. And that central cannula went through the right anterior thoracotomy. And that worked pretty well for us. It made access at the right thoracotomy a little bit difficult because it's not a very large incision. And actually, we had a couple of patients who came down who were on pre-op ECMO, and they were all cannulated fem-fem. So we chose to go right from the ECMO to bypass using the femoral cannulas, and we had no issues whatsoever. So we actually chose then to continue on with that cannulation strategy for our subsequent patients. And we liked it. It didn't change too much for us on the perfusion side. We had good line pressures, good flows, and the surgeons liked that they had a little bit more visualization on that right side. We used the Biomedicus cannulas for this, and about partway through we started getting the next-gen cannulas. If you use the Biomedicus, you probably know what I'm talking about. The next-gen cannulas just had a few slight changes, and our surgeons really actually enjoyed them. So if you're starting to use those next-gen cannulas, you can take maybe with a grain of salt my experience, but we liked the cannulas and they worked well for us. Timing was a little bit of a concern for us as we started doing these minimally invasive approaches. We were concerned that the procedures were going to take much longer. We weren't quite sure what to expect as far as that went. But in fact, our pump times were not too much longer. They were slightly longer on average, but it didn't prolong the procedure too much. So we, like we had done with our full sternotomies, we didn't cool these patients, and that really didn't change as far as that aspect. One thing that we did learn along the way, if you can picture when you have a full sternotomy and your surgeon cores the LV, they have a very nice reservoir to catch the blood at that point and drop the weighted sump into the chest and send all that blood back to you. We learned the hard way that with a left thoracotomy, where you are just looking straight at the LV, once that coring knife comes out, the blood is not going to sit nicely in the thoracotomy. We lost a good bit of blood onto the floor the first time that we did this, and then decided that in preparation for coring the LV, our surgeons kind of cued us into that, and we would make sure that we had the sump turned up, and they would core the LV and immediately drop our weighted sump into the LV. So a minor detail that after the first mishap, we knew better with the subsequent patients. One of my favorite things that changed with this minimally invasive approach was that we implemented a new timeout procedure. And this really was a secondary timeout, we called it, and it was spearheaded or initiated by the perfusionist because our surgeons wanted us to do this immediately before coming off bypass. So it was the responsibility of the perfusionist in the room to make sure it happened before we started weaning down. We covered all sorts of things, made sure everybody was on the same page before coming off bypass. One of those things was to make sure that Flowland had been started on the patient. Every single one of these patients got Flowland before coming off of bypass. And then we would check in about blood gases and electrolytes. One thing that was quite a bit different was that at the point of weaning from bypass, we made an effort to drive down our PCO2s. We maintained normal PCO2s throughout the entirety of the bypass run up to this point. But just before weaning, we would drive down those PCO2s, and I'll get into the reasoning behind that in just a minute. And then finally, this really wasn't important to the minimally invasive approach, but we did add in the HMS at the point of doing this study. So I decided to add that here. That was one technology that was fairly new to us at that point. Okay, so hypocapnia. There is a lot of mixed literature on this. There are some things that you can read that say it is bad in every single way. There are some things that you can read that say there are a few benefits that we can glean from hypocapnia. And the reason that we chose to sort of have this transient hypocapnia during weaning was that there is some evidence that says that there's some pulmonary vasodilation that happens with the hypocapnia. And our goal was really to reduce rates of RV dysfunction. So the Flowland, the intact pericardium over the RV, and the hypocapnia, all three of those were efforts to reduce our rates of RV failure. So these are just a couple of articles that I found with conflicting evidence about the hypocapnia. But we chose to, again, just implement it for a very transient time to hopefully optimize all of the conditions for weaning from bypass and hopeful reduction in RV failure. And one topic that's probably very concerning to all of us is the staffing considerations for this. I know that everybody does this a little bit differently, and this is what worked well for us at the University of Rochester. I'm not by any means saying that this is what you should do or what you need to do, but this is what worked well for us. We had, for every single VAD procedure, 2 perfusionists assigned to the case, and that was from beginning to end. So there were a few reasons for this. One of them is the timing of the procedure. Our surgeons didn't give us the okay to open the VAD, scrub in, build and prime until about the same time that they were heparinizing the patient. So obviously at that point in time, you need 2 perfusionists. There's one who's scrubbed in and building the VAD, and there's one who's preparing to go on bypass. And then later on in the procedure, there were times that the surgeons wanted us to turn the VAD on and de-air, and then actually turn the VAD off again. While that's something that probably one perfusionist can handle while on bypass, it was nice to have a second set of hands in there for that. And then finally, during weaning, we did a very, very slow wean from bypass. Our surgeons wanted to be able to watch the echo, make sure that we didn't have any septal shift. And then also, you wanted to be able to very controlled, very focused, wean from bypass, ramp up the VAD, and make sure that the patient was handling that transition well. And then the times that I found it most beneficial to have 2 people in the room were the times where we were starting to introduce more technologies. So we had patients who were coming down just within this 10-patient cohort. We had patients who came down on pre-op ECMO, patients who came down on pre-op Impella, pre-op balloon pump. So the transition from those devices over to bypass can occasionally be busy. It can be a little bit chaotic. And it was nice to have a second perfusionist in the room for that point in time. And then luckily in this cohort of patients, we didn't have any who were failure to wean. But in those times, it is always nice to have a second person. Whether you need an RVAD, whether you need ECMO, whether you're going on and off bypass, it's nice to have a second person there. So that's why we had 2 dedicated perfusionists to all of these cases from beginning to end, just for the things that we knew were coming and the things that we knew could come. So from our 10-patient cohort, these were our outcomes. Beyond this, there was a larger study that was done. It hasn't been published just yet. But we saw some really great outcome measures here. So our total length of stay, our ICU length of stay, both of those were reduced from the median sternotomy group. Our transfusion rates, we had 1 of the 10 patients who got a transfusion, so not terrible in a small group. That doesn't sound so great, but I'm excited to see the data from the larger group. The intubation times were down. RV failure was way down. We had a 0 incidence of RV failure. So again, I'm excited to see what the larger group of patients shows. But our surgeons felt that this was really, really due in part to that intact pericardium. So the idea is that the intact pericardium over the RV helps to keep the geometry of the RV and doesn't allow it to kind of balloon out. So a simple idea that could have a very big impact on the future. And then we had a 0 incidence of stroke, also a very good outcome. So while the HeartMate III was approved only for median sternotomies up to this point, we got FDA approval. We, as in everyone, got FDA approval for the alternative approach, the minimally invasive approach, in July of 2019 for the HeartMate III. So we have that now for all 3 of our VADs. And we wouldn't be a cardiac surgery group. We wouldn't be perfusionists and cardiac surgeons if we weren't looking toward the future. So what we were able to accomplish beyond this point is probably equally as impressive as what they had accomplished up to that point. They are now able to do aortic and tricuspid valves through the right thoracotomy incision. So valve repair, valve procedures doesn't negate a patient from being able to get this minimally invasive procedure. So a left atrial appendage closure can be done through the left thoracotomy. Mitral valve repair or replacement can be done through the LV apex, through the left thoracotomy. With the help of Dr. Knight, we were able to accomplish all of these different valve procedures through the bilateral thoracotomy approach. Also, sort of one of Dr. Knight's endeavors since my departure from the University of Rochester is that he has a lot of connections in the minimally invasive world, and they feel very strongly about the benefits of simulation. So they were able to take the minimally invasive LVAD procedure and put it into a sim lab, into a simulation environment, so that other surgeons who want to take this approach and implement it in their own hospitals, they can come and they can practice and they can learn these different procedures and techniques before they go and actually implement it. So some really great things that are also coming out of the University of Rochester. A few things that have been documented at the University of Vienna, not yet here in the US. I'm interested to see if it actually does take off at all. But the idea of using only one thoracotomy. So this could be in our future. That left thoracotomy incision would still be there to access the LV. But the idea here is to use an alternative outflow site. And in this picture, you can see that they're using that left subclavian artery. Again, the concern here is hyperperfusion of that left arm. So if you can balance the flow through the left arm, this might be a potential for us in the future. It's just one thoracotomy. And then finally, this has been, again, since my departure, luckily and unluckily, but what they've started doing now at the University of Rochester is actually doing some off-pump VAD insertions. And I say off-pump, what they were doing was using ECMO. So patients who are on ECMO came into the OR, and while they were cannulated fem-fem for ECMO, they just stayed on ECMO and did the VAD implant. I have heard through some of my former colleagues that this is working. So we'll see if they have some publications coming out about it here in the future. But that is on our horizon as well. And then this second bullet point here is very interesting to me. This is also out of the University of Vienna. And as far as I know, not yet attempted here. But if you look at this, it sounds a lot like our TAVR procedures. So it's a completely off-pump VAD insertion. They use pump standby for it. But what they're doing is they're using the bilateral thoracotomies. They're placing temporary pacing wires, and they're rapid pacing the heart, placing the LV coring knife, and then stopping the pacing. They're allowing hemodynamic recovery at that point with the knife still in the LV. And then once they've gotten recovery, they start to rapid pace again. They remove the LV core and then place the inflow of the pump into the LV. At that point, they're stopping the pacing, allowing recovery, and the outflow graft is placed with a simple partial clamp, side biter clamp on the aorta. So they're doing completely off-pump, pump standby VAD insertions there at the University of Vienna. So I imagine it's only a matter of time before some of us start to see at least the likes of this in our practices here in the US. So I'd love to answer any questions that people have about minimally invasive VAD insertions. As I said, I can't give enough credit to the team at the University of Rochester for the things that they're doing on the forefront of all of this, but I am very appreciative for my time and experiences there.